As physical therapists, we hold a unique power. We don't just treat injuries, we restore. Function, hope, quality of life. Think about it for a moment. Elbow, wrist, hand. From a simple handshake to typing an email, from lifting a child to creating a masterpiece, these intricate structures are essential. When pain or dysfunction strikes this vital chain, a patient's entire world can feel like it's grinding to a halt. That's where we come in. Our ability to accurately diagnose and effectively treat these conditions is not just a clinical skill, it is a life-changing service for our patients who depend on us to get them back to doing what they love. Let's start at the elbow, a classic hinge joint, often a source of frustration for our patients. One of the most common conditions we see is lateral epicondylitis, more famously known as tennis elbow. Despite its name, most people who get this have never even held a tennis racket. It is an overuse injury affecting the tendons that attach the wrist extensors to the lateral epicondyle. Think of it as tendinopathy from repetitive stress leading to pain, weakness, and difficulty with gripping activities like holding a coffee cup or turning a doorknob. On the other side of the joint, we have its counterpart, medial epicondylitis, or golfer's elbow. This affects the wrist flexor tendons which attach to the medial epicondyle. It is an overuse injury, typically from repetitive wrist flexion or forceful gripping. Think of a carpenter hammering nails all day, a weightlifter curling with poor form, or a golfer's swing. Pain localizes to the inner elbow and can radiate down the forearm, making simple tasks feel monumental. Another frequent visitor is olecranon bursitis. The olecranon bursa is a small, fluid-filled sac at the pointy tip of the elbow. It cushions, allowing the skin to glide smoothly. It can become inflamed and swollen, often called student's elbow or Popeye elbow, from a direct blow, prolonged pressure, or underlying conditions like gout or rheumatoid arthritis. The result is a noticeable, often tender swelling. We also see nerve-related issues, with cubital tunnel syndrome a prime example. The ulnar nerve becomes compressed or irritated as it passes through the cubital tunnel. Patients report numbness and tingling in the ring and little fingers, weakness in the hand, and a dull forearm ache. Prolonged elbow flexion, direct pressure, or anatomical narrowing can provoke symptoms. Anatomical variations may make the tunnel narrower than usual. Recognizing these patterns sets up effective, targeted care as we move distally toward the wrist and hand. Moving down the arm, we arrive at the wrist and hand, an incredibly intricate area with small bones, ligaments, and tendons working in harmony. Perhaps the most well-known pathology is carpal tunnel syndrome. It involves compression of the median nerve within the carpal tunnel. This nerve supplies the thumb, index, middle, and part of the ring finger, and powers some thumb-base muscles. Compression produces numbness, tingling, and burning pain, often worse at night. Another common tendinopathy is de Quervain's, affecting tendons on the thumb side of the wrist. Inflamed sheath restricts tendon motion. Common causes include lifting a baby, gardening, and certain sports. Hallmark pain at the thumb side, worse with gripping, pinching, and twisting. Wrist sprains often follow fouche, commonly injuring the scapholunate ligament. Finger sprains from sports cause pain, swelling, bruising, and instability. Trigger finger, inflamed pulley thickens, tendon catches and snaps, often in the ring finger and thumb. For tennis and golfer's elbow, the primary mechanism is repetitive microtrauma. Imagine a rope being frayed in the same spot. That is what happens to tendon tissue. Repeated wrist extension, flexion, or gripping loads the tendon insertion at the elbow. Over time, tissue breakdown exceeds repair, causing degeneration and pain that disrupt daily tasks. In nerve compression, pressure and position drive symptoms. Like a kinked hose, flow is restricted. Signal transmission is impaired. Swelling from repetitive motions, direct pressure, or anatomy narrows the tunnel. Reduced perfusion leads to numbness, tingling, and eventual weakness. Acute wrist sprains arise from fouche. Forced hyperextension stretches palmar ligaments, tearing if load exceeds capacity. De Quervain's and trigger finger stem from friction and sheath pulley thickening that constrict tendon glide. A thorough and systematic assessment is foundational. Begin with a detailed subjective history. Tell me about the pain. When did it start? What makes it better or worse? Listen for mechanism clues, repetitive tasks, a new hobby, or a specific traumatic event. Clarify the symptom quality: sharp pain, dull ache, or numbness and tingling. The patient's story is your first and most important diagnostic tool. Let the history guide your physical exam and preliminary hypothesis. Observe for swelling, redness, bruising. Compare with the uninvolved side. Note any muscle atrophy suggesting nerve involvement. With permission, palpate key structures: lateral and medial epicondyles, carpal tunnel, anatomical snuff box, and thumb base. Identify precise tenderness to pinpoint involved tissues. Assess active then passive range, noting pain and end-feel restrictions. Test wrist extensors, flexors, and intrinsic hand muscles. Compare sides. Resisted wrist extension reproduces tennis elbow pain. Resisted wrist flexion provokes golfer's elbow. For CTS, use Phelan's 60s wrist flexion and Tinel's tap median nerve. For de Quervain's, Finkelstein's reproduces sharp radial wrist pain. For cubital tunnel, sustained elbow flexion provokes ulnar symptoms. When treating lateral and medial epicondylitis, begin by managing pain and reducing tendon load. Start with education, relative rest and activity modification. Identify specific aggravating tasks, racket grip, mouse technique, and modify them. Suggest a vertical mouse and frequent breaks. A counterforce brace worn just below the elbow can dissipate forces and ease daily activity pain. Introduce gentle stretching as pain settles. Wrist extensor stretch for tennis elbow. Flexor stretch for golfers. Hold 20-30 seconds several times per day. Begin isometrics. Palm down press for tennis elbow. Palm up press for golfers. 30-45 seconds. Progress to eccentrics. Tyler twist for extensors. For golfer's elbow, assist up and slowly lower into wrist flexion. Controlled loading stimulates collagen remodeling. Integrate functional progression. Shadow swings to foam to regular play. For office work, refine typing posture and grip mechanics. Ensure kinetic chain efficiency. For carpal tunnel syndrome, reduce pressure on the median nerve. A neutral wrist splint, especially at night, prevents flexed sleeping postures that raise tunnel pressure. Keeping the wrist straight maximizes tunnel space and lets the nerve recover. Coach neutral wrist during typing and tool use. Use soft tissue work to reduce flexor tightness and gentle carpal mobilizations to optimize mechanics. Add median nerve gliding. Coordinated arm, wrist and finger positions that slide the nerve to improve mobility and reduce adhesions and symptoms. For de Quervain's, calm tendon sheath inflammation with activity modification. Avoid forceful gripping, pinching and twisting. Use a thumb spica to immobilize wrist and thumb. Ice for pain and swelling. Begin gentle pain-free ROM. Progress to isometrics for thumb abductors and extensors, e.g. hand flat, lift thumb with gentle resistance. Progress slowly. Reintroduce graded gripping and pinching without sharp pain. Always look up and down the kinetic chain. Elbow or wrist pain may originate proximally. Poor scapular control or cuff weakness alters mechanics and overloads the forearm. Think tennis elbow. Always screen cervical, shoulder, and thoracic regions. Addressing proximal deficits can resolve distal symptoms and prevent recurrence. Incorporate ergonomics, chair height, neutral keyboard and mouse, wrist support, monitor at eye level, and optimize tools, lifting, and micro breaks. Use clear language and analogies, fraying rope for tendinopathy, a kinked hose for nerve compression, and provide illustrated handouts. Education builds ownership, patients become active participants. Set expectations, progress fluctuates. Teach good pain, muscle soreness, versus bad pain, sharp joint tendon irritation. Use activity logs to spot triggers and celebrate wins, like opening a jar or sleeping through the night. So there you have it. We have journeyed from elbow to fingertips exploring common pathologies that profoundly impact our patients. From repetitive strain like tennis elbow to nerve compression in carpal tunnel, thoughtful, systematic care is key. Break problems down, understand mechanisms, perform precise assessment, and apply targeted interventions. Be thorough and holistic, never treat the diagnosis, treat the person. Connect posture and shoulder function to wrist and hand pain. Use eccentrics, nerve gliding, ergonomic changes, and splinting, tailored to the individual. Back in clinic, take a detailed history, examine meticulously, confirm with special tests, educate, modify activity, and progress exercise. The power to restore function is in your hands. Thank you for everything you do.